you very much for inviting me to this short conference. I hope I will bring you up to date with the current, in a way, treatment of rheumatoid arthritis. And I was the Vice President Global for the College of Physicians, but I demitted office a year ago. But I am still a consultant rheumatologist and professor of rheumatology at Barts on the London. Now, rheumatoid arthritis, in spite of all the research that is done, it's really its cause is unknown. And in fact, rheumatoid arthritis is a new disease which probably started in the 19th century, because there are no records or none of the mummies or the skeletons that have been discovered all over the world have shown any evidence of rheumatoid arthritis, unlike ankylosing spondylitis and gout and osteoarthritis. And no doubt one of the best predictors for the development of rheumatoid arthritis is the CCP antibodies and rheumatoid factor, and they could really precede the onset of the disease by up to 15 years. And if you have both the IgM rheumatoid factor and CCP antibodies, then the risk is almost 50%. 50% could develop rheumatoid eventually within 15 years. Now we still have really no cause for it, but we do know there are 3 risk factors for especially developing the anti-CCP positive subset of rheumatoid arthritis, and one of them is smoking. And smoking tends to be forgotten, but it's important also when patients do not respond to treatment. If you ask them to stop smoking, some of them do get a better response, because smoking reduces the enzymes in the liver. Obviously, we share epitopes, and if you have more than one allele, the risk is higher. And more recently, the 620WPTPN22 allele is a risk factor. And in fact, this allele is also present in some patients with type 1 diabetes. And in fact, the only link between type 1 diabetes and rheumatoid arthritis is this allele. So those with type 1 diabetes who carry this allele may develop rheumatoid arthritis. So it is important, but quite often forgotten. Now, let me start with this patient, a 47-year-old woman. She gives a 7-week history of joint pain involving the hands and wrist, with tiredness, prolonged early morning stiffness, and she had trouble taking off her wedding ring. You could see this is a very useful sign. I call it the wedding ring sign, because if you see it, it means the patient must have a recent inflammation of the, especially obviously of the PIP joints. And it's a good sign that this is an inflammatory arthritis. She was a smoker as well, and the GP treated her with NSAIDs, but her symptoms persisted. Nowadays, as soon as the patient comes, we put the probe on their hands, and you can see that this is the left finger, the MCP of the left finger, and you could see the synovial thickening. And when you put the Doppler signal, you could see this is on the right side. You could see how hot it is. So there's no doubt that this is inflamed. And this is another view. You could again see this is the right index finger, and you could see the Doppler and the thickening of the synovium in the MCP joints. And her investigation shows you she's slightly anemic, her CRP is raised, the CCP antibodies and rheumatoid factors were very high, but normal bone profile and normal liver function test. And obviously, this is rheumatoid arthritis, and the problem is we need to treat these patients as soon as possible with disease-modifying medication. Otherwise, you could see in this slide, this is the natural course of the disease. This is disability over the years. But if you start treating earlier, then the outcome is better. And if you try and start immediately, the outcome is much improved. So the sooner, the better. Now, and you have to remember that damage occurs early in most patients. Half of the patients will show joint space narrowing within a very short time. By 10 years, half of the young working patients are out of work. And death occurs early for multiple reasons, usually comorbidities. And compared to the general population, women will die 10 years earlier than their peers, and men lose around 4 years of life. And you can see that within 3 months, 26% of patients develop erosions. Within a year, nearly 2/3, and within 2 years, around 3/4 develop erosions. And as soon as you made the diagnosis, I would advise everyone to do the disease activity score, because I think that's terribly important. And severe disease is when the DAS is more than 5.1. If it is between 3.2 and 5.1, it's moderate disease. If it's lower than 2.6, then the disease is in remission. And this is really helpful so that you could plan and revise the treatment every 3 to 6 months. So always do DAS. This is part of the treatment. And also, we always forget. Now we immediately go to drug medication. Remember, you have to teach the patients about the drugs, about the importance that this disease would need years of treatment, probably lifelong. They have to stop smoking, splinting of joints, exercise, nutrition is important, and they may need help with activities of daily living. So that we mustn't forget these aspects of treatment. And the smoking, I would encourage people to smoke, because this shows that really, if you have the shared epitope and you have ever smoked, then the risk could be up to 21 compared to controls who never smoked. So even smoking a little bit could. And as I said, it's important to stop smoking, because you may get suboptimal response from drugs like methotrexate and others. And also, it's very important that at every stage of the treatment, you should get the patient involved. And you explain that your aim is to get remission. If you can't get remission, then you could attempt really low disease activity, and every 3 to 6 months revise the treatment, do the DAS, and if the response is suboptimal, escalate the treatment, and so on. Sorry, and really, in a way, at every step, you should get the patient involved. And obviously, immediate for symptomatic treatment, which is really not terribly effective, because even anti-inflammatories are much less effective than in patients with ankylosing spondylitis. And paracetamol have some benefit. And please do not use anything with codeine and dihydrocodeine, because they are addictive, and I think it's not a good idea. Immediately start the patient on the best treatment, which is methotrexate. If for one reason or the other they can't tolerate methotrexate, then you could try leflunomide or sulfasalazine. For mild cases, you could try hydroxychloroquine. And I always really use a small dose of prednisolone, generally no more than 15 milligrams, aiming at weaning the patients off the prednisolone within 6 months. Now, prednisolone not only has the best anti-inflammatory effect, but also there is evidence that when it's used, it has disease-modifying effect. So steroids are useful, but they should not be prolonged. It doesn't matter how you give the steroids. Some people give it by intramuscular injection, pulsed methylprednisolone, or oral. I think the oral route is much better, because you could control the dosage. And in all the recommendations, this is the EULAR recommendations, the NICE recommendations from the UK, and the ACR, they all recommend methotrexate as the first step in the treatment. And if you don't get an optimal response from 10 or 12.5 milligrams of methotrexate, escalate the treatment. Some people may need even 25 milligrams of methotrexate. So escalate the treatment, and if there is no response, add sulfasalazine. If there is no good response, add in hydroxychloroquine. And it's always possible, if the oral methotrexate is not useful, it's worth trying subcutaneous methotrexate. So in a way, at some stage, we used to start with the triple therapy. Now, the advice from the experts is to have a step-up strategy. Now, the problem is some patients do not respond to this initial therapy. And in a way, the criteria for failure to achieve remission or low disease activity, the patient has maximum methotrexate tolerated dose, and yet there isn't a good response when it comes to the DAS. The patient still requires more than 7.5 milligrams of prednisolone a day, or requiring multiple injections every 2 to 3 weeks, and there is evidence of progression of erosive disease on X-ray. So this is really important. Now, if we don't get a good response, then we have plenty. We have 5 different classes of drugs that we could use. We have the TNF inhibitors. We have the B-cell depletion rituximab, and we have abatacept as the co-stimulation blockade, IL-6 inhibitors, and the JAK inhibitors. Now, really, in a way, although their effectiveness may vary, I would suggest that you use whatever is available to you. You could use it. If it's available and it's cheap, I would go for the cheapest of the lot. I wouldn't restrict myself to using one or the other, because some patients will have to pay a large amount of money for it. And now most of these drugs are really very safe. We have used them for a long time, and also there is evidence that when you use these drugs, there is also evidence that the comorbidities are less serious. Now, if the patient still have some response to methotrexate, it is best to add in the biologic or the targeted synthetic DMARD. It's the outcome is better if they're used in combination. Although some of the targeted therapy can be used on their own, but all the evidence, and I've listed a number of papers for you to show it is better to use them in combination. I'd use the cheapest, as I said, which is available for you and which is the most affordable. I would go for it. In our institution, we tend to use, if the patient doesn't have a good response to rituximab and they are CCP positive, we tend to use rituximab or abatacept. But if they are seronegative or the CCP antibodies is not very high, we tend to use tocilizumab, IL-6 inhibitor, again, plus methotrexate. But if the rituximab is contraindicated and you can't use, you could use then one of these others. You could use abatacept, you could use abatacept or any of the other. If you use already one TNF-alpha, try another one, or try one of the JAK inhibitors or the IL-6 inhibitors. And if the methotrexate is contraindicated or withdrawn, then you could use monotherapy with these drugs, because all these 3 groups can be used as monotherapy without the need for methotrexate or leflunomide. So any of the JAK inhibitors, any of the IL-6 inhibitors, or these 3 TNF inhibitors, or their biosimilar, because the biosimilars are cheaper. Now, it's really important. This is a very good review, which was published in the New England Journal of Medicine around 3 weeks ago. And I would strongly advise you to read it, because they are looking at the immune-mediated diseases. And they said in many of these diseases, rheumatoid, colitis, psoriatic arthritis, or spondyloarthritis, the common effector phase is the inhibition, is TNF-alpha. So if you inhibit that, these diseases get better, but the response varies. And the reason for that, because the main in a way, the main signature cytokine or cells vary in these diseases. Obviously, TNF-alpha inhibition is not good for every immune-mediated disease. For example, multiple sclerosis could be made worse with TNF-alpha. If we look at rheumatoid, the main cytokine signature is interleukin 6, and the B cells. So if you block the B cells with rituximab or stop their function with abatacept, then these two treatments, these are the only two treatments that will in fact reduce the level of the antibodies. While if you look at colitis is interleukin 23 and interleukin 13, and these, the effector cells are T helper 9 and 17. If you look at Crohn's, it's Th17, interleukin 23, psoriasis, interleukin 23, and interleukin 17A. And spondylitis is mainly 17A. So in a way, when it comes to rheumatoid, possibly the IL-6 inhibition is possibly more specific for rheumatoid, because it's the only disease of the immune-mediated diseases where IL-6 is the major signature cytokine. And however, it does not lower the autoantibody level in rheumatoid arthritis, nor it works preferentially in CCP positive RA. It just works. And also, IL-6 receptor inhibition does not necessarily have a higher therapeutic efficacy than the TNF alpha inhibitors. However, there is no doubt it's more specific for rheumatoid arthritis. The other interesting thing about IL-6 inhibition, it does not require methotrexate for treatment, although we recommend that you give it with methotrexate. And the same applies for the JAK inhibitors. They also work mainly through inhibition of IL-6, and also they can be used without methotrexate. The main advantage of, in a way, blocking IL-6 is, unlike TNF-alpha inhibition, it does correct suppressed bone formation RA. So it is the only one, although the erosions will regress on anti-TNF, but they will not start healing. Unlike if you block IL-6 with JAK inhibitors or sarilumab or tocilizumab, then there will be healing, so with some repair of the erosive disease. So I think this is really terribly important, and I would suggest you look at this paper perhaps in one of your journal clubs. It is really very informative. Now, if a patient, the problem is you give them, for example, biological DMARDs, and a lot of the patients, 20 to 30% of the patient develop, well, at the beginning, 20 to 30% never responds. So the primary failure, but sometimes the patients after 2 years, the response declines. And then you have the problem, is it because the drug has lost its effectiveness, or is it because they develop anti-drug antibodies? If they have the anti-drug antibodies, then it is worth trying another TNF-alpha. But if there are no anti-drug antibodies, there is no point. It means that the patient has failed to respond to that pathway. But no doubt, this is why I think we always say give methotrexate, because if you give methotrexate with these biologics, it increases effectiveness, and also it is less likely that the patient will develop anti-drug antibodies. Obviously, the most immunogenic is infliximab, because it's chimeric. Then comes in adalimumab, sartorizumab, golimumab, while Enbrel, etanercept, because it's a receptor construct, is the least immunogenic. Abatacept also low immunogenicity, rituximab a little bit more, toci very little, and obviously the JAK inhibitors, because they are synthetic DMARDs with the small molecules, there is no immunogenicity. Now, there are a few things I want you to remember. If a patient, for example, has bronchiectasis or COPD, and it is quite often patients with COPD do have rheumatoid arthritis because the citrulation starts in the lungs. So in that case, use the drug which causes least infections, and that is either etanercept or abatacept. If a patient has diverticular disease, then try to avoid tocilizumab or sarilumab because they could lead to silent perforation, and especially if they are taking NSAIDs or steroids. Now, the third note is that if the patient has interstitial lung disease, then please try rituximab or abatacept because there is evidence they work very well in that situation. Now, a few more. With regards to malignant melanoma, no doubt, the risk is high with TNF inhibition. And in fact, Prof. Chirio and myself reported the first 2 cases must be 18 years ago. So I think this is a genuine concern. With non-melanoma skin cancer, there may be a positive association, but not as strong as when it comes to malignant melanoma. And obviously, patients with psoriasis who have already had some phototherapy or PUVA, they are at a higher risk. And there is less evidence that the risk of non-melanoma skin cancer is in those receiving non-TNF biologics. The targeted, the JAK inhibitors, well, there are 4 of them now. The upadacitinib inhibits JAK1, tofa inhibits 1 and 3, and baricitinib inhibits 1 and 2. They have, this is how they work. The reason why they are called Janus, the word Janus is because they have 2 heads, because Janus had 2 heads, head on the outside and head on the inside. And in a way, what happens is when they block the JAK, they stop working, and therefore the transcription from the nucleus will stop, and this is how they work. So essentially, it binds to JAK, and so it stops the JAK stimulating the signal transducer and activator transcription, and therefore there will be no gene transcription. And this is really how they work. They're very sophisticated. You see that they block them, and therefore there'll be no gene transcription. This is how they work. And as I said, it's Janus because they have 2 heads. And the key cytokines of the pathogenesis of rheumatoid are these, but in fact they inhibit those, especially IL-6. So in a way, that's the way they work. But there is 2 important points. It's no doubt it can lead to activation of tuberculosis, very similar to anti-TNF. And although there is higher incidence of herpes zoster, they very rarely get very severe herpes zoster. So it is a genuine risk, higher than with others, but it is not life-threatening. And we have still more are coming on the pipeline. You could say, why do we need so many? It's because there are still 6% of patients with rheumatoid are resistant to all these treatments. And the second thing is that again, recent evidence shows that patients, 5-year survival of newly diagnosed rheumatoid, they survive, 80% live for 5 years compared to 88% of controls. So the treatment is not optimal as yet. And in fact, 3 days ago, EULAR published the difficult to treat RA and their definition, but this is outside our talk today. And in fact, they have an algorithm to show if they do not respond, how do you deal with these patients? So again, I think that's for you to read. It's accessible, free from the Annals of Rheumatic Disease. So in summary, early diagnosis, early treatment is very, very important. Prompt therapy is important to avoid long-term damage. And just to remind you, this is 1993, for those of you who are old enough. This is in the primer of rheumatic diseases, the textbook of the Arthritis Foundation in the USA. And this was the treatment in 1993. Education, rest, exercise, NSAID. If they don't respond, then transitional DMARDs, and all along give them steroid injection or do surgery. 1993. That's not too far away. And that reminds me of Harold Macmillan, the Prime Minister of the United Kingdom in the late 50s and early 60s, when he said, let's us be frank about it. Most of our people have never had it so good. And thank you very much.
Thank you, Professor Ali Jawad, so for a lovely talk. So our next speaker in line is Professor John Axford. So unluckily, he's not going to join us live today. So his talk is pre-recorded. And in a moment, our host is going to take us to his slides. Here we are.
Very many thanks for inviting me to 3 topics in rheumatology. Part of our global initiative. Our last meeting was in December 2019. And thank you goes to Nighat, Sumaira, Ahmed, Saira, and all the others in the Lahore, the fantastic Lahore rheumatology team. As usual, congratulations to you all for your endeavors, because it's been a very difficult 18 months. And I should like to point out that your activity is significantly greater than those of your neighbors. You really remain very active throughout all these challenges that we have had. And also congratulations, Ahmed, to your new job and to your elevation to a chair. That's a great achievement. What I'm going to do is give you a very clinical talk, and it's going to be in two sets, so you can divide it up in future if you wish. It's not going to be a boring up-to-date, but I'm going to tell you a little bit about clinical vasculitis in my clinic. So I'm going to tell you a little bit to begin with about diagnostic pitfalls in the diagnosis of ANCA-associated arthritis, associated vasculitis. So this was a referral for Zach, who you see was born in 1989, and good short ENT referral, please see nasal congestion with discharge. And he said there that he had normal ESR and CRP, but he had a PR3 anchor of 5.7. This was in lab 1. The reason why I'm telling you that will be apparent later. And he said, is this granulomatosis with polyangiitis? A biopsy was not taken at that time. So 30-year-old Zach came to see me. He's a civil engineer. He builds tunnels under London. And he had a 2-year history of nasal discharge, and he described bloody, fleshy lumps. He had a chest rash, hearing loss, childhood asthma, polyarthralgia, and he had an odd story of a transient seizure in 2016, giving him a transient left hemiplegia, but neurological investigations were quite normal. This is his rash. I don't know whether you can see my arrow here, this red raised rash, which was non-pruritic. And when I examined him, he had this red rash, he was short of breath, and my working diagnosis then, based upon what I was seen in the referral letter, was that he had an ANCA-associated vasculitis. So he had a PR3 positive ANCA vasculitis with nasal discharge, rash, asthma, polyarthralgia, and neurological involvement in the past. So I sent him off for an MRI brain, HRCT of his lungs, PET scan, and blood investigations, and started him on 30 milligrams of prednisolone, methotrexate, and cotrimoxazole. He came back 2 weeks later. He said his breathing was very much better, but what was strange was all his scanning was entirely normal. And because I'd seen the patient in a different hospital from the person that was referring to me, his immunopathology was sent to a different lab, and the ANCA came back as negative. Acute phase reactions negative, full blood count normal, but he did have an eosinophilia of 0.95 to 1.2. So I thought, well, we'll stop the immunosuppression, repeat the blood tests, get a nasal biopsy done, and check the ANCA in 2 different labs, so I understand, and just see why there was a discrepancy between lab 1 and lab 2. So the investigation then came back showing that his eosinophilia had gone up to 1.62. So there was an atopic inflammation going on. One used an automated FADIA 250 way of checking for ANCA, and that came back as IgA antiproteinase 3 positive at 5.8, which is quite large. Lab 2 uses a non-automated method, which is their usual method, and that was negative. They then put the sample through an automated method, and that came back positive 3.8. So this was my first dilemma. The first dilemma is the disparity of results between 2 methods for the detection of, let's move this out of the way, anti-proteinase 3 antibodies. And this was actually, I searched this down, this was actually a BSI, British Society of Immunology poster by Rachel Wheeler and Joe Sheldon, who I've worked with for the past 30 years. And they reported that patient samples can be positive for PR3 antibodies by one assay, by not the other. And their explanation of this is that the PR3 epitope is accessible to in each assay in different ways. And there are differences in the affinity of each patient's antibody to the accessible epitope. And there's variation in antibody subclasses. So using one method, it may be positive. Using another method, it may be it may be negative. So that was my first dilemma sorted out. So I came to the conclusion that his ANCA positivity was indeed positive. We then got a nasal biopsy, and this showed ulcerated necrotic tissue, a dense infiltrate of eosinophils, predominant T-cell infiltrate, and this is the picture here. You see there are no granuloma, but there are lots of these eosinophils in the nasal biopsy, and there's significant necrosis in the biopsy. So my working diagnosis was eosinophilic granulomatosis with polyangiitis, the old Schur-Strauss syndrome. I put him back on maintenance immunosuppression with azathioprine, cotrimoxazole, and prednisolone, and his clinical progress over this time was continued with recurrent flares of nasal discharge and stuffiness. Steroids went up to 30 milligrams a day. This triggered 3 admissions to a local psychiatric hospital here for quite serious psychotic behavior. It was as a result of one of these admissions that the discharge summary indicated that he was a cocaine user, but he reassured me that he had not been using cocaine since adolescence. And then lockdown got in the way, and the patient was lost to follow-up for 6 months. He came back to see me after lockdown, and he was still complaining of acute flare of nasal discharge and stuffiness despite immunosuppression. And again, my investigations came back showing that he was positive for proteinase 3 using the automated method. Eosinophils had gone back down to normal, and the acute phase response was normal. I sent him back to the ENT surgeon, who said that his left nasal passage was normal, his right nasal passage was horrendous. So we've got a systemic disease causing localized inflammation to the right nasal passage. She did more biopsies showing a respiratory type mucosa with a dense infiltrate of plasma cells, lymphocytes, eosinophils, and neutrophils. And the granulomas and vasculitis were not seen at multiple sites of the biopsy. So you see again, eosinophils, a lot of necrosis, but no granulomas. Eosinophil account resolved, so there was ongoing inflammation, but eosinophils had decreased. And why was only one nasal passage affected? So another one of my dilemmas. I then had a chat with our friend David de Cruz, and he had published this little paper on cocaine and ANCA-associated vasculitis-like syndromes. And he reported on 12 patients with significant sinus thickening on observation, erosive disease in the nose, multi-system manifestations of vasculitic rashes, pulmonary lesions, and peripheral neuropathy, positive ANCA at presentation, managed by immunosuppression, but then cocaine use was determined at a later stage. And David de Cruz feels that there are certain patients that have cocaine-induced pseudo-vasculitis. So could this be cocaine-induced ANCA-positive pseudo-vasculitis? Since then, the patient has gone AWOL, as we say, and I haven't seen him because, of course, my next diagnostic will be to do a drug test and see whether he's got cocaine in his blood. So my pitfalls in the diagnosis of eosinophilic granulomatosis with polyangiitis was that initially I was wrong-footed because the ANCA tests were disparate between two labs. Symptoms continued in the patient despite immunosuppression, perhaps because he was continuing to take cocaine in his right nose. Eosinophils resolved, and he had a very unusual clinical representation with the unilateral nasal inflammation. Other pitfalls in the diagnosis of eosinophilic granulomatosis with polyangiitis is that asthma treated with glucocorticoid steroid therapy may suppress clinical signs of EGPA. The initial manifestations of EGPA can occur on their own. They don't need to occur together. And some manifestations, e.g. asthma, can occur for many years without the realization that this patient has a vasculitic disorder. And only looking through the literature, 40 to 60% of patients with EGPA actually have a positive ANCA anyway. I've had one other patient who has a similar presentation since Zach, and for some reason, cocaine users like using one nostril. So there you go, we learn something every day. Other differential diagnosis of EGPA, aspirin exacerbated respiratory disease, AERD or Sapter's triad, chronic eosinophilic pneumonia, allergic bronchopulmonary aspergillosis, and hypereosinophilic syndrome. So the conclusions here and the take-home message here is if there's a clinical suspicion about vasculitis and IgG anti-PR3 antibodies are negative, recheck with another method. Always take a detailed drug history, and this may avoid patients taking immunosuppression when they don't need to. And question your diagnosis if the clinical features don't add up, e.g. why is one nasal passage affected and the other is not. So Assam O Alaikum, this is the end of my first part of my talk, and these are the London Rheumatology Clinic team at your service in London. So this is the second part of my talk today. Congratulations on putting on 3 topics in rheumatology in these testing times, a part of our global rheumatology education initiative, and I very much look forward to coming out to the hall in person for a proper meeting. I thought I'd amuse you a little bit here. These are scenes in and around London. I'm sure you have similar things in Lahore where people get a little bit hysterical about COVID. So this is a sign in the middle of a local town saying, COVID-19, reduce your car speed. Well, I haven't quite worked out what the relationship is between car speed and COVID-19, but people were taking it seriously. This is a funny I got on my WhatsApp saying COVID-19 testing in the rear, and the thought here is, oh, I thought it was a nasal swab. You've probably had lots of restrictions on how many people are allowed in one room. So this says only one person can come in this room, and guess where I found the sign? But it was in the lavatory. So there's no sense in these things, but they keep you amused. So until November last year, I don't know about you, but I have never seen chilblains before. I probably used the word, but I've never seen them, and indeed none of my children had suffered chilblains. And this is until November. And from November till May, I have had a tsunami of chilblains, and now they have suddenly dried up. So what was driving this? I saw 20 patients, so you can see that's quite frequent over this short period of time. large age range between 7 and 58, but 7 patients less than 20, 14 female, 6 male. They were all negative for SARS-CoV-2 antibodies, 1 consistently RNP positive and 1 consistently with reduced complement C3 and C4. This is the sort of history you get from this 15-year-old girl. 6-week history of bilateral finger swelling pain, blue discoloration, reduced dexterity. Her father was SARS-CoV-2 positive, she wasn't. Previous history at 9 months of Kawasaki disease. Examination, new hand Raynaud's and chilblain. She was the lady who was ANA positive, RNP positive, SARS-CoV-2 negative, normal physiology and normal acute phase reactants. I initially treated these patients with oral corticosteroids, prednisolone. My colleagues at the Royal Free, who were seeing similar patients, and of course they were in a large acute hospital and were somewhat gung-ho, and they were treating adults, used 120 milligrams of depomedrone. My dermatology colleagues told me to use Elicon cream, which is a fairly strong topical corticosteroids, and I found that to be better for these patients. So this is what this 15-year-old looked like. She had these very acutely painful chilblains over her fingers here, and these occurred over a 2 to 3 week period with, as you can see, a new onset Raynaud's phenomenon. This is before treatment, and this is after treatment, and you can see that with time and with corticosteroid cream, the inflammation resolves. This is another young girl who was 8 at the time, 2-month history of new onset Raynaud's affecting her hand. Third toe, no COVID in her or the family, previously celiac disease. An examination revealed Raynaud's affecting her hands and the feet, chilblains affecting the tips of her left, second and third toes, COVID negative, ANA negative, acute phase reactants normal. And you can see this is this young girl here with chilblains affecting the tips of 3 toes. Not as severe as my last patient, but again, a fairly novel finding with new onset Raynaud's. And here's a close-up. And really quite painful, particularly in areas of inflammation such as this. And you can see for a young girl, quite ragged cuticles. This is Rosie, she's slightly older, she's in her 40s, and she was one of my more severe cases. Again, a 2-week history of symptoms affecting the right fingers, painful and stiff, skin discoloration, reduced dexterity. She had primary Raynaud's over many years. I'd never met her before. 3-week history of swelling pain, skin discoloration of their first and fourth distal phalanges. Examination, Raynaud's affecting hands and feet, chilblains, right fore and middle fingers, left foot distal phalanges. Immunopathology negative, SARS-CoV-2 IgG negative. I tried her with oral corticosteroids, later replaced it with topical Elicon. This is on presentation, and what was interesting about her, and I subsequently saw this in quite a few places, was this very severe inflammatory chilblain just sitting over the nail fold here. This was intensely painful, and this is a few weeks later, and what is interesting is as the nail grows out, here, where's my pointer, the inflammatory damage is seen under the nail itself, and this grows out of the nail, and in Rosie, the whole nail fell off, and you can see lessening chilblains affecting the hands here. But I treated Rosie for probably about 4 months. This is her MRI demonstrating significant soft tissue edema associated with reactive bone marrow edema. So this is her forefinger with significant soft tissue edema and reactive bone marrow. So not only is the inflammation affecting the skin, the nail, but it really goes right down into the bone itself, hence why it's so painful and disabling. And this is the distal phalanx of her left foot, where there's again inflammation associated with the chilblain associated with the left foot. This is a young girl who's 15 and she presented with hands like this, which I think are quite horrendous. And again, this was slightly older, over about a 6-week period of new onset Raynaud's, chilblains, and here significant ulceration affecting her hands. And you can see this is a young girl, and her hands are significantly swollen, significantly painful. This is after a short period of topical corticosteroids, and you can see again she's experiencing the nail fold changes that my last patient was also experiencing, but quite rapidly local corticosteroid caused resolution of the inflammation and the ulceration. And her hands here are really quite horrendous. This is a stir image showing diffuse bone marrow edema of the 2nd to 5th MCPJ. Wrists unaffected here, soft tissue edema affecting the soft tissues of all the here. So this is quite remarkable amount of edema and inflammation affecting the fingers. And this is the left hand, showing similar changes affecting the left hand, bone marrow edema and soft tissue inflammation. This is another lady. I've omitted to show her photographs, but she was one of my first with inflammation affecting the left hand, 3rd and 4th digits, and the right hand, little finger. And this is another patient just showing a sagittal view, showing the edema of the middle and distal phalanx of the hand here. And again, the same patient showing marked soft tissue inflammation and bone marrow edema of the right hand. So in my view, I have never seen anybody or MR images of chilblains. I've never seen chilblains looking quite like that. But it was really quite astonishing to me that in the absence of an acute phase reaction, the inflammation was really quite significant. So 20 patients presenting since mid-November, 3 new onset Raynaud's, quite young age, all negative for SARS-CoV-2 antibody, 1 RMP positive with significant MR imaging of the hands and feet. So if you look through the literature, there have been 74 papers between March 2020 and January 2020, so I should imagine there'll be more. No one is reporting Raynaud's, so this was a unique finding here. But what this French paper, Spanish paper demonstrated when they did biopsies was that you've got SARS-CoV-2 endothelial infection causing COVID-19 chilblains. And they did histopathology, immunohistochemistry, and ultrasound of 7 pediatric cases. And they were able to extract the SARS-CoV-2 virus from the skin of these patients. So it looks as though SARS-CoV-2 is causing an infection. This strain managed to cause skin inflammation and particularly inflammation affecting the hands and the feet, causing chilblains, otherwise known as vasculitis. So really quite interesting in that this variant has swept through the clinic. I don't know what your experience is in Pakistan, whether there are probably different variants causing significant hand and foot vasculitis, discomfort in patients. As the virus is removed from the body and immunosuppression is given, then the inflammatory vasculitic lesions resolve. But am I the first person ever to MRI a chilblain? Assam alaikum, many thanks for your attention. I hope I've given you something interesting to discuss. And please let me know what your experience is of 1, cocaine-induced vasculitis, and secondly, SARS-CoV-2 antibody vasculitis. Thank you.
So welcome everyone back after this very exciting talk by Professor John Axford. We are really honored to have this afternoon with us Sarfaraz Hasni. I have already introduced him. So he's the Director of Lupus Clinical Research at National Institute of Arthritis, Musculoskeletal and Skin Diseases. Dr. Hasni is going to talk on difficult lupus, managing difficult lupus. Over to Dr. Hasni.
Thank you so much, Ahmed. And first of all, it's a wonderful seminar that you've arranged, and kudos to you and rest of your team at the Central Park Medical College and the teaching hospital, as well as the Arthritis Care Foundation. And thank you to Dr. Professor Nigat Mir, Professor Sumaira, Dr. Bilal, and Dr. Saira, and others who have given me this honor to come and talk to you. And I really enjoyed the two talks before me, and I hope I can keep up the standard of presentation, as they have set a very high bar. So without further ado, let me just share my screen and see that. So Ahmed, is this viewable to all of you?
Yes, it is.
We can see your slide, Dr. Hasni.
Okay, thank you so much. All right, so so the task is really sort of a difficult task for me to talk about managing difficult lupus in a very short time period, and obviously it's a long topic, and there a lot can be said about it. So I'll start with some disclaimers. So first of all, I don't have any financial conflict of interest, and these are my personal opinions and not the official statements of the NIH. I may mention some of the off-label use of medications. And again, it's not a comprehensive review, but I have provided references along the slides. For anyone who is interested to read more about it, they can go through those references and read. In terms of objectives, I thought that we'll talk a little bit about the diagnostic dilemmas, what are the treatment options for these complicated lupus patients, and then what are the outcome measures that we should look for difficult to treat lupus. So we'll start with the first scenario, and as most of you, especially the rheumatologists in the audience, know that most of our lupus patients are young women of childbearing age. So invariably, while taking care of patients with lupus, the issue of pregnancy during lupus will come about. So either patients are planning to get pregnant, or they're pregnant when they presented. And of course, patients with lupus have much more higher incidence of pregnancy-related complications because of the disease itself, and also the incidence of pregnancy-related complications such as preeclampsia, and the fetal complications are also much more high. And this is due to a multitude of reasons. So one reason is the immune dysregulation associated with lupus, then the anti-phospholipid antibodies present in certain lupus patients, as well as some fetal-related related complications, and presence of some autoantibodies such as anti-SSA and SSB autoantibodies, which are associated with not only neonatal lupus, but also congenital heart block. So, so it's a very complicated problem, and when we face a patient with lupus who is pregnant and is experiencing some medical problems, it's sometimes very difficult to tease out whether the patient has these problems related to lupus flare, or is this something such as preeclampsia or some other pregnancy-related complications going on. So with this sort of the stage, I'll go with the first case, and I thought that we will discuss it in somewhat of an interactive manner. And I'll present the first case that one of the patients that I've seen and taken care of. It's a 32-year-old female who has lupus and is now presenting at 34 weeks of pregnancy with bilateral lower extremity swelling. In the past, she was treated for lupus nephritis with cyclophosphamide, and then about 4 years ago, she had a flare, which was again treated successfully with cyclophosphamide. At the outset of the pregnancy, before about 8 months ago, she had a 24-hour urine which showed 1 gram of protein, but there was no sediments, and the serum creatinine was 1 milligram per deciliter. And today, when we examined her at the time of presentation, her blood pressure was high, was 148/98, and she did not have anything overtly suggestive of a lupus flare, such as a hair loss or a lesions, arthritis, or a rash. Whereas the pertinent finding on her examination was that she has a 2+ pitting edema of the bilateral lower extremity. So the first question here is that which of the following combination of tests is most compatible with the diagnosis of preeclampsia? And I'm not sure if the poll is up for this. Okay, so if you can go and look at the sets of lab, and between A, B, and C, and D, please choose your answer, and I'll wait for about 30 seconds. Very well. So while rest of you are still going through this, I will share the results, and then looks like that most of you thought it was C. So let's see what the real answer is. Okay, here it is. So yeah, so the answer is C. And the reason being is that the uric acid was significantly high, which is usually the case in preeclampsia, and the 24-hour calcium was less than 100. In addition, there were no urinary sediments, and the creatinine level was normal. So I thought that I'll present to you sort of a checklist, which is not a comprehensive checklist, but will help in terms of differentiating whether it's a preeclampsia or a lupus flare. And I put down some of the timings, the clinical findings, as well as the lab findings that might help guide us one way or another. Just keep in mind that sometimes it's extremely difficult to differentiate between a lupus flare, especially if it's a nephritis flare, and preeclampsia. And sometimes patients can have both a preeclampsia and a lupus flare at the same time. But in terms of timing, preeclampsia almost invariably happens at 34 or more weeks of pregnancy. The blood pressure is always elevated. There is a significant amount of proteinuria, but the sediment is usually bland. The liver transaminases are usually high. The thrombocytopenia is present, but it can be present in lupus patients also. The thing that I wanted to highlight is that uric acid level is invariably high, of more than 5.5 in preeclampsia, whereas it's low in lupus flare. And the 24-hour urine calcium, if it's available for you, will be less than 100 in preeclampsia, whereas in lupus it is usually as high. The complements can be normal in both cases. The one thing to mention here is that in lupus pregnancy, the complements level can be falsely normal, because as a response to pregnancy, the complements are usually falsely elevated. And if there is a step down, yes, meaning that if you're looking at a trend, it could mean that the lupus levels are, the complements level are falsely normal, even though they are being consumed. And the headache is usually present in preeclampsia, whereas it's usually less commonly present in lupus flare. So now with this first outset, let's go to the second question. And again, I'll ask the audience to put in the poll. So the presence of which of the following has the highest positive predictive value for pregnancy loss after the first trimester or 12 weeks of gestation in women with anti-phospholipid antibody? So it's the anti-beta 2, anti-cardiolipin, lupus anticoagulant, or prior pregnancy loss. So if I can have the poll up, please. Okay, so it seems like we've kind of leveled off here. So, so I see with the responses that it's pretty evenly divided, and I see that there is almost 40% of you thought it was lupus anticoagulant. So let's see what the evidence show. So it did show that the lupus anticoagulant is the highest positive predictive value, even though the rest of them also are predictive of pregnancy loss, but lupus anticoagulant is the highest. So what does this data come from? So there are numerous studies that support this finding, and I will quote one of there from Mike Lockshin and his colleagues from New York, who have looked at 144 pregnant patients, and out of those 28 had adverse pregnancy outcome. And they found that the patients who have lupus anticoagulant are overwhelmingly the ones who had an adverse pregnancy outcome. The other thing that they found that the patients who have IgG anti-cardiolipin antibodies, they were also were predictive of a worse adverse pregnancy outcome, but especially if they are in addition to IgG anti-cardiolipin, if they were positive for lupus anticoagulant, it was significantly higher. The other antibodies like the IgG anti-2GP1 or IgM anti-2GP1 did not predict adverse pregnancy outcome. Another interesting finding from this was that they looked at the bivariate analysis, and they found that patients who had a prior incidence of thrombosis were significantly associated with an adverse pregnancy outcome. Interestingly, prior pregnancy loss did not predict adverse pregnancy outcome, and in triple positivity, which is positivity of ACL, anti-2GPI, and lupus anticoagulant, did not predict adverse pregnancy outcome better than just the lupus anticoagulant. So in summary, the point I wanted to make here is that checking lupus anticoagulant is very important if somebody comes in desiring to be pregnant or pregnant while they present to you for the first time. Now going to next slide. I wanted to talk a little bit about this landmark study, which is the PROMISE study, the acronym for predictors of pregnancy outcome, biomarkers in antiphospholipid antibody and systemic lupus erythematosus. Again, this was a huge study which was multi-center. It was primarily done by Jill Boyan and Jane Salmon from the NYU. And this study has resulted in multiple papers over the last 6 or 7 years. And it was a landmark study with 385 pregnant patients with lupus who were compared to 198 healthy controls. And in addition, they have a third cohort of patients who have antiphospholipid antibody syndrome without lupus. And they were looking at the patients and follow them longitudinally in terms of the idea was to identify the risk factors and mechanism of adverse pregnancy outcomes. The interesting point from this study is that about 81% of the pregnancy were uncomplicated. So it means that overwhelmingly the patients with lupus do well when they get pregnant. But the caveat here is that most of these patients were had mild or no disease activity, and they were in a very controlled setting. So it may not be extrapolated to normal clinical practice, but in the clinical trial setting, most of the pregnancies were uncomplicated. The adverse pregnancy outcomes were more likely based on this study in patients who are African Americans or Hispanics, may not be so relevant to the audience in Pakistan. The BMI of more than 30 was predictive, as well as presence of lupus anticoagulant, again, confirming the studies results from earlier studies. And the low platelet, especially a platelet count of less than 100,000, low complement 3 and 4, use of an antihypertensive medication, meaning that if patients were hypertensive at the start of the pregnancy, they were more likely to have an adverse pregnancy outcome. The lupus flare in the second and third trimester was also predictive. Interestingly, glucocorticoid use was not associated with an adverse pregnancy outcome. When they did the multivariate analyses, and I will come to the last point later on, the multivariate analyses, the 3 factors were very highly predictive. So having a non-white ethnicity, a positivity of lupus anticoagulant, and low platelet count of less than 100,000, and use of antihypertensive medications were the most highly predictive of having an adverse outcome in patients with lupus. The interesting thing, which is more of an academic interest that I would just very briefly mention here, and of course, these are tests which are not available clinically, but an interesting data that was previously known in the preeclampsia literature was again found to be true in patients with lupus, that the adverse, the novel biomarkers, which are the soluble VEGF receptor or SFLT1, was found to be highly predictive of an adverse pregnancy outcome. And just to give you a quick background is that the placenta produces these VEGF receptors, and sometimes there is an alternate splicing of this receptor. And what happens is that this soluble receptor, when it goes into circulation, it binds with the vascular endothelial growth factor and placental derived growth factor. And when it does that, then these factors are not available for the angiogenesis. And we all know that the VEGF and PIGF are necessary for a healthy endothelium and the placental growth. So as a result of this high levels of SFLT1, the VEGF and PIGF are not available and becomes in a placental insufficiency. And this thought to be the major driver of preeclampsia. And of course, there are multiple caveats. And again, it's more for research and academic interest. It's not something that is ready for prime time in terms of the clinical use. But I thought that was an interesting finding that was known in the preeclampsia literature, but was found to be true in the pregnant patients with lupus also. And I've given the reference at the bottom of the slide. And if somebody is interested in reading more about it, they can, they're more than welcome to go and refer this. And if anyone needs any of these reference articles, they can email me and I'll be more than happy to send them the PDF versions of these. All right. So now let's move on a little bit and then go to this next question, where this is based on a very recent study from a large teaching hospital in China, where they have looked at a large number of lupus patients, and they found that the fetal loss in pregnancy was associated with the following 3 variables, which independently predicted fetal loss after they adjust for the confounder. So if I can have the poll up again to just keep your brains stimulated and keep you involved. So again, it's a little bit of a tricky question because I'm asking for 3. So out of these 5, 2 are wrong answers. Okay, good. So we'll end the polling here in the interest of time. I'll just share the results. And as you can see, there's an even spread of the answers. And let's see the answer. So out of those 5, the 3 which are shown to be independently predictive of fetal loss were unplanned pregnancies, low C3, and proteinuria of more than 1 gram per 24 hours. Interestingly, in this study, the pre-pregnancy hypertension was not found to be associated with the fetal loss, but it could be that maybe the numbers were small, or there were not so many patients with hypertension in this population. The presence of anti-double-stranded DNA, interestingly, in multiple studies, have never shown to be associated with an increased events of adverse pregnancy outcome. So, so looking at the data from this study, the references at the bottom of the slide is that unplanned pregnancy has an odds ratio of 2.8. The low C3 had an odds ratio of 5.4, and a 24-hour urine of more than 1 gram per 24 hours had an odds ratio of 5.8. Even though the confidence intervals are very wide, so there is a lot of scatter in the data, but at the same time, these are very high odds ratio of having a fetal loss after adjusting for the confounders. And based on this, they have created a risk score, and there's a lot of discussion about using this risk score in pregnant patients with lupus. And the risk score was calculated by having the 3 predictors added together with a weighted addition. So it's not a simple addition, which is the unplanned pregnancy score was given a weighted score of 1.04. Hypocomplementemia was given a weighted score of 1.7, and 24-hour urine protein was a weighted score of 1.7. So adding these together, then they divided the risk score into a lowest score, which is between 0 to 3, and a high risk score, which is 3 and above. And it had a very high specificity of 93.3. The sensitivity was rather low. So it means that the positive likelihood ratio was 9, whereas the negative likelihood ratio was 0.4. So if somebody was in a high risk group, meaning that they have a score of 3 and above, the chances of having a fetal loss or an adverse pregnancy outcome were extremely high. Whereas if they were not present, there was still, there is a chance of adverse pregnancy outcome, but it was not as sensitive. So based on all of this data, what I wanted to leave with the first part of my talk is to develop some kind of a pregnancy risk assessment. So when a patient comes in, you can use this as a checklist when to assess how well they are going to do in the pregnancy. And like I said, most of the pregnancies in lupus patients do well if they are well planned. So so the first thing is that looking at them, if it is unplanned pregnancy, if the lupus was active at the time of conception. And again, another factor that we have not talked much about is use of teratogenic medications such as mycophenolate mofetil at the time of pregnancy. Low complement level, presence of the lupus anticoagulant, presence of proteinuria, especially if it is more than 1 gram per 24 hours, prior history of any thrombotic event such as DVT or PE or such, presence of hypertension, BMI of more than 30 kilograms, and presence of anti-SSA and SSB antibodies. So this is not a comprehensive list, but it gives you somewhat of a checklist that you can use in your clinics when you see a patient to see how you can do the risk assessment for patients with lupus in terms of whether they're going to do well or not so well with their pregnancy. The last slide of this part of the talk is sort of giving you a quick management update for your approach for pregnancy in lupus. So the first thing, which is the most important thing, is to do preconception counseling. And as famously being said, that You need to have a plan before you actually need a plan. So planned pregnancies do well, unplanned pregnancies don't do well. And it's very important that anytime a patient with lupus comes to you, you should do the preconception counseling and tell them about the risks and do's and don'ts, and make sure that they're getting pregnant which is a planned pregnancy. So avoiding an unplanned pregnancy, and defer the pregnancy until lupus diseases activity is in remission for at least 6 months, because studies have shown that patients who get pregnant where disease is in remission do very well, whereas the patients who have high disease activity don't do so well. Using hydroxychloroquine throughout the pregnancy is also very important, because it has been associated with good pregnancy outcomes. Discontinuing the teratogenic medications such as mycophenolate mofetil, with a caveat that as a knee-jerk response, please avoid an abrupt withdrawal of all immunosuppressive medications. Of course, you need to stop the teratogenic medication, but for example, patient has an azathioprine or any other medications, don't just suddenly stop all those medications because the patient is pregnant, because that is again associated with an increased risk of having a flare and also bad pregnancy outcome. And I just do want to talk a little bit about the use of low-dose aspirin, and it has been recommended by several groups to use them in all lupus patients, but that's somewhat debatable. But at least patients who have the positive anti-phospholipid antibodies or positive lupus anticoagulant do consider using low-dose aspirin, as it has been associated with a improved or better pregnancy outcome. Using low-dose aspirin with the low molecular weight heparin in prophylactic doses in patients who have antiphospholipid syndrome with history of miscarriages or preeclampsia, and then using the low molecular weight heparin in the anticoagulation doses in patients who had history of thrombosis associated with antiphospholipid syndrome, along with aspirin, is recommended. I do want to leave a resource for patients. It's something which is created by Lupus Foundation of America. It's available in 3 languages, in English, Spanish, and Chinese. But if somebody would like to translate it in Urdu or any other local languages, they can contact Lupus Foundation of America. And if they allow you to do that, then you can use that as a good resource, because education and counseling is very important to have a good pregnancy outcome. So with that, we'll just quickly switch gears and go to the next part, another difficult to treat lupus, which is, as you can see from the picture, is going to talk about the neuropsychiatric lupus. So again, starting out with a case that I've recently taken care of. It's a 46-year-old female who presented to us with some cognitive and behavioral changes. She was diagnosed with lupus almost more than a decade ago, with malar rash, oral ulcers, arthritis, and alopecia. And she had hematological abnormalities, had immunological abnormalities, and she was noted to have some insidious, rather, cognitive and behavioral issues. So it was not so sudden. Her exam was normal, and her complements and DNA was positive. And this is not a significant change from her baseline. So these were always positive. So she was always serologically active. The rest of the labs are normal. And because of the cognitive and behavioral issues, even though we asked her to get the MRI and lumbar puncture, but she refuses. So this created a diagnostic dilemma. And I just want to see what you guys also think about this diagnosis of this patient, which is a very challenging patient that we recently take care of. And if I can have the poll up for this, or do we have the poll for this? Okay, good. So looks like most of you are thinking that this neuropsychiatric lupus, and this is indeed a very challenging case for me to take care of, because again, we were very limited, and this is what I kind of felt like after I looked at this patient. It's very enigmatic, and we were really stumped in terms of how to make the diagnosis in this patient. So just to give you a little bit of a background that why all of this confusion and why it is so difficult to treat patients with neuropsychiatric lupus. So in 1999, the American College of Rheumatology came up with some nomenclature and case definition, and it's an exhaustive list, but I just wanted to give it to you to show you the complexities associated with this diagnosis, is that there are 19 neuropsychiatric syndromes which are shown to be associated with patients with lupus, and out of those, 12 were related to CNS and 7 to peripheral nervous system. And there is a whole range of things that can happen and are associated with neuropsychiatric lupus. So it's indeed a very challenging diagnosis to make, just based on so much complexity and so many diversity of the clinical presentations that can be associated with CNS lupus. Now, I do want to talk real quick about the pathogenetic pathways, and a lot of work in neuropsychiatric lupus is done from Italy, from Dr. Govani and John Henley from US. And when you search the literature, most of the articles are from these two. I just took advantage of a recent review by Dr. Giovanni and Henley, which was published in Rheumatology in December 2020, and basically just gives you a framework in terms of trying to how do we think about the neuropsychiatric lupus. So there are primarily two autoimmune pathogenic pathways. So either it could be in the ischemic path, or it could be the inflammatory path. The ischemic path is mostly associated with the antiphospholipid autoantibodies, immune complex and complement activation leading to thrombosis, which could be either macro or micro, and angiopathy and so forth. But the presentation clinically could be very similar to the other pathogenic pathway, which is more of an inflammatory driven, meaning it is more of an autoantibody related, and a lot of cytokines and mediators are released. And what it does is that it leads to an increased blood-brain barrier permeability and leads to multiple pathogenic changes secondary to that. So these are two different ways how neuropsychiatric lupus on a pathogenic pathway can happen, but the clinical events can all look very similar. But if we are able to tease them out, the treatment is somewhat different. And then at the bottom are the non-lupus related causes that can also lead to neuropsychiatric manifestations. And it's important to differentiate whether it is driven by lupus, underlying lupus, or it is a non-lupus cause. So it could be the complication of lupus itself, or the complications of the lupus therapy. For example, the steroid psychosis is very well known, or patients who are on immunosuppressives can have CNS infections. And secondly, the lupus patients are also allowed to have neuropsychiatric diseases which are outside the lupus. So it could be primary CNS vasculitis, Alzheimer's, or any psychiatric illnesses such as schizophrenia or depression and what have you. So that's why it's a very complicated way to first identify whether the manifestations are related to lupus or non-lupus, or if it is related to lupus, whether it's more driven by the ischemic pathway or the inflammatory pathway. So some of the help can be through using this table, which has recently been proposed by the group in Italy, and they come up with this attribution of neuropsychiatric events to lupus, because that's one of the most challenging part, whether the clinical manifestation that you're seeing are attributable to lupus or not attributable to lupus. So without going into much, because we don't have much time, but they divided them into 4 groups, and then see whether under this table, what is the time of onset, whether it is minor or not specific events, or if there are any confounding factors, or if there are additional favoring factors present or not. And based on these 4 items, they come up with a scoring system of 0 to 3. And they found that if somebody has a score of more than 7, the positive predictive value of using this table is 86.3. And if they have a score of less than 3, the negative predictive value was 85.7. So which is fairly good in terms of multiple biomarkers that we use. It's quite comparable to that. In fact, better than some of the biomarkers that we use. So even though we don't have a good biomarker to diagnose a neuropsychiatric lupus, if you use this table, it will at least help guide us in terms of how to think about the clinical presentations in the patients. The diagnostic workup I just listed here just to provide some what of a framework for you. So of course you want to look at the general assessment of lupus, and you want to rule out any underlying secondary causes that can lead to neuropsychiatric manifestations such as thyroid dysfunction, vitamin deficiency, or any toxicology screen. Autoantibodies, you want to make sure that you look at the anti-DNA and antiphospholipid antibodies. The anti-ribosomal P and anti-NMDA or NR2 antibodies have been widely quoted as associated with neuropsychiatric lupus, and we all tend to use them. But if you look at them, it actually have a very limited utility, and they have not been able to pan out. And there are conflicting results in literature about the utility of. So I'm not too fan of using them in regular clinical practice. But if you do check them, if they're positive, sometimes they're helpful. But I don't personally found them extremely helpful in terms of diagnosis, even though we all check it all the time. Of course, doing a lumbar puncture and CSF analysis is a must for any patient with neuropsychiatric illness to rule out any underlying infection. Neuropsychological testing is important, EEG, especially in patients who have seizures. And imaging studies, CT scan, MRI, and the more newer imaging techniques, which are the functional imaging, and I'm not sure how much of it is available. They're not widely available even in US, so other parts of the world, they're not so much available. So the MR spectrography or SPECT scans or PET scans also give us some idea in terms of what is going on inside the brain, not only in terms of the structure, but also the functions of the brain. So in terms of the diagnosis, and this is the last slide, again, the reference is at the bottom. So please refer to these for further discussion about this. So if we determine that the cause of the neuropsychiatric manifestation is secondary to lupus, we would treat them aggressively. We would give them IV pulse steroids and cyclophosphamide in using the same lupus nephritis NIH regimen by going to 500 to 1,000 milligram per meter square monthly for at least 6 months. Supportive care is very important in these patients, and having a multidisciplinary approach, getting help from your psychiatric and neurologist colleagues, putting the patient on antipsychotic is sometimes needed. If they are having seizures, giving them anti-seizure medication. And of course, if it's a high chances of thrombotic event, giving them anticoagulants are also very important. In refractory cases, we have used rituximab. In fact, we have used rituximab and cyclophosphamide combination with very good results in patients who are not responding to cyclophosphamide alone, but there is a caveat in terms of a high increased risk of infection. So this is something that you have to be very careful. And if you would like to discuss more with me, I can talk to you offline about how we have used the rituximab and cyclophosphamide successfully in refractory or recalcitrant cases. And the last but not the least is the hematopoietic stem cell transplant. And in our institute, we have used it for few patients to treat them for if they are not responding to cyclophosphamide alone or rituximab and cyclophosphamide combination. This is somewhat of a last ditch effort to treat them, but you would need a very highly specialized tertiary care unit to go for a hematopoietic stem cell transplant. So this is sort of a framework in terms of how we can think about treating patients. Just coming back to the case that I initially mentioned, interestingly, we treated her with IV pulse corticosteroid and cyclophosphamide. And after 3 months of treatment, she did show a significant improvement. Her cognitive behavior returned back to her, almost to her baseline, and she was again a functional individual. So it was very satisfying to see a patient who presented with rather insidious onset, and then after all the challenges that we overcome and make the treatment decision, she did respond very well to that. And with that, I will end and say thank you again to all of you, and especially to Professor Ahmed Saeed. And I'll stop sharing here. And
thank you, Dr. Hasni, for a very enlightening talk. I may request now our chairs, Professor Nikhat and Professor Sumaira, for their comments. We'll start off with Professor Nikhat Mir Ahmed.
Assalamu alaikum. It is a great pleasure, honor, and a privilege for me to be a panelist in this excellent session. I think at best, I should say, and also chair the session. This journey actually started when I met Dr. John Ashford in a meeting, and he pushed us to join the Global Teaching Initiative, and then introduced John to us and Ali Jawad. and which finally culminated in an excellent teaching session in 3 teaching hospitals and institutions, including 2 universities, which was, I think, a landmark for Arthritis Care Foundation, for Royal College of Physicians, and for Royal Society of Medicine, because it was for family physicians, it was for residents, it was for medical students, and it was for rheumatology faculty and rheumatology training. And I think we need mentors and leaders like John really push you. And sometimes you're like, you can't do it, but he doesn't give up. That is fantastic. So he kept us, driving in the driving seat. So that's why we have this session in this COVID situation where we couldn't meet personally. And Dr. Jawad, I still remember your last day of teaching at Fatma Jinnah Medical University, where Bilal was hosting it. And, we were there till 5 p.m. or 6 p.m. And you injected my carpal tunnel and did very well, I must tell you. And that was a demonstration to the trainees how to inject carpal tunnel. And we really hope that we'll meet soon, because these were, and Ali, the way he led the musculoskeletal ultrasound session. So I think ACF, our SM and RCP are working, fantastically with the same goals of teaching, training, and now with research. And Hasani, who has been here quite a number of times, is somebody like a find for which we are so happy to have him in this initiative. And the way he has involved all of us and in training, education, research, that's fantastic. And we recently signed an MOU with NIH, where Hasni, can I make that public? Where we are going to be doing genetic research together with NIH. So all facilitated by Hasni. So each one of you has done wonders through our teaching, training, and this initiative is there to stay. I'm going to really, be missing my duty by not mentioning that our team obviously works with passion, with love for rheumatology, works day and night. And Ahmed, you have really put in your sweat and blood in starting the teaching program at Central Park. And all of us have a support in the form from Dean, and also from the principal. And hopefully, it will lead to an Institute of Rheumatic Diseases, which is going to be a state of the art, which our dream is, to have a place where everybody can get treatment, affording, non-affording, and we can do research and we can do teaching. So congratulations, Ahmed, for organizing this conference, Dr. Fakat and the team, Mariam at Central Park. And I would also Bilal and Saira. Now, John, since we left our RSM initiative in 2019, there are 3 more places where teaching program has started. One is Gulab Devi Teaching Hospital, National Hospital and Medical Center, Shalimar. So FJMU already had it, and Central Park. So this is all in Lahore. And ACF has really supported this initiative. And Sumaira will tell us about the detail. So this is all good news. And before I wind up, I really want to appreciate the great talk by Jawad. He is a great teacher. I should say, teacher of teachers, and the way you teach and put the clinical touch in your talk. He spoke so well about rheumatoid arthritis, and the highlights of the talk. I hope everybody remembers what he spoke about, the biologics, and what we have to look for, and how do we select which treatment for which patient. These are important tips, and the New England Journal of Medicine reference which you gave, I'm sure it's would be great for our fellows, for our faculty, for our trainees. Excellent talk and excellent. It's like, what we say is having the river in a little cup. In Darya Kuze mein band karna. Ahmed would be able to translate it much better. So next was John's talk. Very interesting cases, John, and chilblains and Raynaud's have been a challenge for us. But unfortunately, we haven't seen it here so much during the COVID. At least I haven't, as you had asked, I haven't seen it. And the talk about the challenges in diagnosing vasculitis and the pseudovasculitis. We all have to always remember this and not forget. There's a lot of cocaine use in our country as well. So how it can masquerade as vasculitis. Very informative, excellent cases. And Hasni, you are going to take charge of lupus in this country. Excellent, brilliant talk also. And touching on pregnant lupus patients, this is very close to our heart, and it's very challenging for all of us, and very interesting cases and the questions which kept us awake. Thank you so much, and I think it has been a wonderful session. Bilal, you must have had more questions here, but before that, I will leave this to Ahmed again, and Sumaira will have give it to you.
Sumaira, so your comments, we are waiting.
Thank you so much, Nighat, for such a lovely intro, wind up, and summary. And of course, you have led from the front and mentored all of us who are listening to this here in Pakistan. I want to just say Assalamu alaikum and a good day to everybody. What fantastic, top-notch presentations we have been honored to listen to from Ali, from John, and from Hasni. I think one of the only good things that COVID has brought in is that we have been able to get into the groove of having more online video webinars, meetings, and educational initiatives. I think that and made it logistically possible for us to interface more often than having to travel long distance. As ACF co-chair, and also, if I may say, the mother of at least 24 rheumatologists that are listening to this, since I was part of their training program. It is wonderful to see at least 70+ participants on a Saturday evening. Ahmed, what a fantastic program you've put together, you and your team. Commend you, and I know that Mariam and Rafaqat have been there with you every step of the way. Great to see Saira and Bilal, probably my eldest child, second eldest child after Shabir, Saira, and Bilal, you're somewhere in the middle. Okay, so great, fantastic, all of you, and working now in so many places, not just in Lahore and not just in Punjab, but also in KPK, in Balochistan, in Sindh and Karachi. So we are blessed that we have been part of this great initiative. And thank you to RSM, thank you to RCP, thank you to NIH and Hasni for joining us in this global teaching initiative. I just want to quickly add that when ACF was conceptualized and when it was finally registered, the aims that we had were clinical care, improving clinical care, research, and education. And out of these, we probably felt that the greatest domino effect would be if somehow we can facilitate education, because of the abysmal ratio of physician to patients in Pakistan, high population, and very, very poor ratio of rheumatologists to patients. And the primary care physicians who interface with most patients have poor access to training or any educational material. And the dream basically was, and I think this was a vision that started with Nikhat, and Saira did a lot of work with her ILR project on that, and Ahmed, and all of us over here, is trying to somehow have access to training, which was easy to access for professionals who are working with a huge clinical load and who cannot take time out to do a structured year or 2-year long training. And in that, proud that Arthritis Care Foundation has actually been part of several initiatives, and this wonderful global initiative with RSM and RCP, and now hopefully NIH is going to be a part of that. I also want to mention that ACF has been working with the South Asian Forum also to bring educational webinars to all levels of professional working with rheumatic disease patients. So from here, fantastic scientific content, great presentations. I'm going to hand this back over to Ahmed.
Thank you, Professor Nikhat, Professor Sumaira, for your kind words of appreciation. I think Professor Ali Jawad has something to say. So he's like a teacher of the teachers. So Professor Ali Jawad, so we are listening, all at ears for you.
Okay.
Sir.
Well, I just wanted to make comments on pity John is not here, but I mean, chilblains are really very common, and the proper name for chilblain is pernio or perniosis. And it is not a vasculitis, it's a vasculopathy, and it's due to the constriction of the blood vessels, usually the autonomic blood vessels. Due to the effect by the autonomic peripheral nerves, and it doesn't really require steroids. You have to keep the hands warm, and the first treatment is to put local steroid, and if it is not enough, nifedipine orally would be useful, and if that doesn't really work, then tacrolimus ointment could be used. And in fact, it does settle down. It's not. I have seen quite a few, not only myself, but my colleagues, possibly because of lockdown, because of all the changes. But no doubt, I sent a copy of a paper, the reference for a paper, Dramatic Manifestations of COVID-19, which has something like 400 photographs of all sorts of skin conditions that occurred in patients with COVID-19. And in fact, pernio is one of them. And in fact, almost any rash could occur with following COVID-19. And, at the beginning, the blood tests were not terribly, because some people may get an antibody response, which we could measure, but some people get a cytotoxic T-cell response, and those may not get antibodies in their blood. So some of them could be the COVID, some of them could be, because I remember as a child, when I was 10 years old, I did develop chilblains, but I was forced to wear gloves and so on, and it got better. I think the reason why you don't see it, because it's warmer in Karachi than in London. I mean, today it's fairly cold outside. It's only 17, and in winter, the temperature is very low indeed. So I think, and if it is resistant to tacrolimus, the Royal Free, in fact, have tried sildenafil a small dose, 25 milligrams, once or twice a day, because they do respond to sildenafil in the same way as, in fact, the digital ischemia, which occurs in scleroderma, responds to that as well. I will shut up now.
Dr. Bilal, so would you be able to screen few questions from the audience?
Yes,
Ahmed, can
thank
I
you.
just comment, just respond to Ali? I totally 100% agree with you, Ali. What a great little summation you gave of chilblains, and we see them all the time in Lahore as well, despite the heat. Yeah, thank you.
Yes, thank you, sir. I think most of the questions have been answered by our panelists in the Q&A session. Just two questions are unanswered. First, one question was asked by Professor Nigat Mir. Either Professor Jawad or Dr. Hasni can answer them. Madam has asked that, are you giving booster dose of COVID vaccine to patients with rheumatic diseases after 2 sets of vaccination? If yes, which one you prefer? Mix and match or the same vaccine as the first two?
Do you want me to go first? Well, I mean, from the studies. Sorry, can you hear me?
Yes.
Yes.
I can hear you.
I mean, essentially, if you look at all the data that has been published recently in the Annals of Rheumatic Disease and others, in fact, our patients have done extremely well. It's the ones that have had a poor response and are those on rituximab. Otherwise, I think in general, they have done well. Now, the government has not. They are still discussing as to who will get a booster dose and what type of booster dose. I think so. I mean, the answer is imminent because this is more of a political decision rather than a medical decision, and so we are governed by the authorities. But I think, no doubt, I think recent studies and the ones we've done in our own laboratory and have shown that really the antibodies wane by 8 months, no doubt. And the incidence of, I mean, the protection is something like 95, 98% in the first 6 months. By the 8th month, the protection is around 50%, so it drops dramatically. And I think we do need a booster. Everyone needs a booster dose. I think anyone above the age of 50, I would say, would need a booster, and more so any patients with immune-mediated inflammatory disease, such as rheumatoid or colitis or lupus. And remember, in 2% of if you give any vaccine, 2% will not develop any antibodies because they may develop just as a T-cell response. So it's very difficult because there is 1 in 50 who will not respond with antibodies, and generally people measure antibodies. We tend to measure both, and we measure IgA, IgG, and IgM antibodies. In fact, IgA antibodies are the most protective because usually the entry is through the nose or the mouth. If you have IgA antibodies, they will block the viruses very quickly, more so than the cytotoxic T response. And any vaccine would be useful by the 3rd time, I think. But it's a government decision, I think.
Yeah, thank you much. I think ACR came out with these guidelines. That's what they wanted. That was their recommendation that after 2 doses, after 1 month, we should just universally give a booster dose to patients with autoimmune diseases. That's one guideline, but I don't know. Is that being followed everywhere or not? Maybe Hasni would let us, guide.
So I think we have been doing this. So both the CDC and the American College of Rheumatology have very clear guidance in this, and they have come up with what you just said, Dr. Nigat, is 28 days after, and they have asked to keep the same medication that they have, the same vaccine that they have received before, so not to mix and match. So that's what we have been doing. Pretty much all the patients who are coming to our clinic, we are giving them booster shots.
Okay.
Yep.
Okay. Thank you so much. Saira, do you want to say something here? Saira, I don't see you.
I have a question, just a question. So we have to mix because of the travel restrictions. So those who have had, Sinopharm or Sinovac, we need to go and get either Pfizer or Moderna for travelers in some locations. So just a clarification from either you, Hasni, or Dr. Ali. Sorry to cut you, Saira. Is whether there's no issue with doing that, right? I
There
just
is
want
no
that.
issue. There is no issue. It's just there is no study to support it. So basically, they just said to avoid mixing matching. But in fact, there are some studies which actually show that mixing two vaccines are actually produce a better response. But that is not for the booster, but just for the first and the second shot. But in terms of the booster, this is what they have seen. But they, I don't think that there is any issue with.
So with those who are traveling are getting the Pfizer or Moderna over here in Pakistan also, but we were thinking that because since it's available, we should be giving our patients who got Chinese vaccine a booster shot with either Moderna or Pfizer.
I think it should be.
Yeah. Thank you so much. Saira?
Dr. Hasni, I just wanted to ask you a question. You had mentioned that you do use plasmapheresis in refractory cases of lupus. Which patients do you use plasmapheresis for?
Yeah, so I mean, the problem is that it's just like a kitchen sink approach. When everything else is failing, you just try whatever you can feel like. So, for example, patients who are neuropsychiatric lupus, I've given them 3 months of IV cyclophosphamide and have given them steroids, and they're still not recovering, especially if they have the cognitive dysfunction. Then you would consider giving them and doing plasmapheresis. So it's mostly recalcitrant patients who are not responding. At least after the 3 months, you need to see some improvement. And at 6 months, if there is no improvement, then you try different things. But to be honest, we don't use plasmapheresis as much anymore. Most of the patients who are not responding to cytoxin, we use rituximab, or we go with the rituximab and cyclophosphamide combination. So that's mostly our second line of treatment now.
So the rituximab and cyclophosphamide combination, how do you use it? Like, do you use it with cyclophosphamide with the first dose of rituximab and the last dose?
No.
Or do you have any other regime?
So our regime is very similar to what David Eisenberg uses in University College London, and we have treated a good number of patients with the same regimen, where what we do is that we start the patient on, give them the pulse steroid, and then give them rituximab at day 1 and day 15, the RA dose, which is 1,000 milligrams, and then at the same time, with the first dose of rituximab, give the first monthly cyclophosphamide. So 3 pulses of steroid, cytoxin, and rituximab in the 1 week. And then after
how much cytoxin do you normally give in such cases?
Start with 500 to 750 milligrams per meter squared, depending on how big the patient is and if they have cytopenias or not. And then titrate it up to 1 gram. Again, this is a very scary regimen. When I first started giving that, I was just very scared. But as I keep giving them, I get more comfortable with it. But you need to have a very thorough discussion with the patient, especially in Pakistan, to make sure that they are safe in terms of infection and also in terms of the side effects. And then we also have to tell them that this is an off-label use, mostly based on literature and also on our personal experience.
Can I comment on plasma exchange? Hasni and Dr. Jawad, do you use plasmapheresis in a patient with lupus who's pretty sick and, considering that infection is maybe an issue? I feel that plasma exchange does have a role in a sick lupus patient who has had, might think, pulmonary hemorrhage or vasculitis. And you cannot use cytoxin, and you can barely use a minimal dose of steroids. And we all know that higher doses of steroids are basically not recommended. So, have you used such a regimen where your hands are tied?
Yeah, so sorry, Dr. Jawad. Just the most of the time we end up using plasmapheresis is when patients have significant cytopenias. So if the white cell count is very low, secondary to lupus, that's when you want to use something like plasmapheresis or even IVIG we have used. But otherwise, or if they have a very high antibody titers. But like I said, I mean, most of the time we are not using plasmapheresis as much anymore. About 10 years ago, we were using a lot. Now it's with the new medications, we are going to mostly going to rituximab, but if in occasional patients, we only use it.
Okay, thank you.
In fact, I think on its own, plasmapheresis is not very useful unless you combine it with something that will kill the producers of the antibodies, and therefore because they will just form again, and it's most useful in patients who have high antibody levels, and so I think you have to combine it with something else. It's not enough. I mean, we use it for neurobiologics arbitrarily, but generally these patients are always given either 6-mercaptopurine or azathioprine or mycophenolate, because it's like IVIG on its own. It's good for acute situations, but it's no good for a chronic condition. So it reduces the antibody load, but then you have to give something else to stop it from forming, and that is how they should be used. However, I think it's generally there is a decline in their use. We only use it for severe cases, neurobiologic, where nothing else has succeeded. Just one other comment on mycophenolate mofetil. In fact, the Department of Health in the UK, we are not allowed to use mycophenolate mofetil in women of childbearing age unless they have 2 methods of contraception. And if they decide to, so they're very, very strict. So you can't just stop mycophenolate and the woman can get pregnant a month later. It has to be at least 6 months. And in fact, they would not, in fact, when we write the prescription, it will not be issued by the pharmacist if the patient is not on at least 2 methods of contraception. Just for that's what
I wish we could do something like this over here.
Can I ask a question?
In a way, it's no. I think. Sorry.
May I ask a question on that? I thought that the BSR 2016 guidelines, you have MMF needs to be stopped 6 weeks before.
I think it's now 6 months according to the government.
Oh, it has been updated to 6 months.
Yes, 2016 is a long time ago. So it is. It is. I think preferably it's 6 months, because really I mean, if you open the BNF, in fact, if you could get it online and you will see what is written there. So mycophenolate mofetil, I think use with caution for women of childbearing age. Otherwise, it's interesting. I don't know whether some of you have seen the New England Journal of Medicine last week. It is being used. They compared patients with ITP, for idiopathic ITP, compared to, so they gave some steroids, they gave some MMF. The response to MMF was much better than steroids. However, there were more patients, the patients reported so many side effects that it had to be stopped. So the quality of life, which is really quite interesting, and that's what we see with young people on MMF, is that their quality of life declines, although they get a good response. It's a wonderful drug, except there are so many side effects. You have to build it up and so on. Just out of interest, the New England Journal of Medicine last week, 2 days ago, the 2nd of September, have a read. It's really worth reading.
So, according to the latest developments with valcosporin and bimavelumab being approved for lupus, I think, I don't know how people will have on board, because that has to be added to the already to regimen a biologic or
I would leave it to Sarfraz.
Thank you so much.
Luckily, I don't see as many lupus patients as he does. But as I said, in fact, it's good in the UK that we have these, these restrictions. In a way, they are led by the chief medical officer and so on, which is quite interesting.
Dr. Ali Jawad, I just wanted to ask you, the latest ACR guidelines are focusing more towards starting hydroxychloroquine or sulfasalazine for low disease activity RA. What is your take on that?
Yes, I think it's very reasonable. In fact, it's in all the guidelines, in the NICE guidance, and in fact in the EULAR guidance, and in the ACR guidance, that for people with palindromic rheumatoid or patients with very mild rheumatoid, you can use hydroxychloroquine in
as
those
monotherapy
patients.
In early rheumatoid arthritis.
Yes, I think you could use it as monotherapy, provided every 3 months you make sure you do a Doppler, make sure there is no activity in the joints. Talking about hydroxychloroquine, if you give it with MMF, in fact, it reduces. It's like you could reduce the dose much easier if the patient is taking hydroxychloroquine, which is very interesting. That's one of the benefits of using hydroxychloroquine to almost every patient with lupus.
So in a patient with a low disease activity,
I don't know whether Sarfraz would make any comments on that. Michelle, in fact, our mother of lupus in the USA, says that. I've got a slide to show, and also it reduces the cholesterol and less osteoporosis. Obviously, less clotting as well. So hydroxychloroquine is a good drug.
No, my question is, wouldn't you be looking at all the prognostic signs first before just giving monotherapy, hydroxychloroquine or sulfasalazine?
Of course.
Because how are you going to the idea behind it is that a window of opportunity that we need to control the disease within those few months before any erosions develop. So,
it is for mild disease. It is for mild disease, and obviously you are following it up very closely. And if you see that they have no activity in the joint, you can do gas, you can do Doppler, you can even
Doppler and the DAS 28. I said I gave you the slide to show if it was.
If a patient has a high disease, high anti-CCP levels and a high rheumatoid RA factor level, but has a low disease activity, would you still consider putting them on hydroxychloroquine or sulfasalazine monotherapy?
With the close monitoring, because I tell you, these patients within 2 years they will develop secondary failure to these. So it very rarely lasts longer. If I find it is the most useful in those CCP positive or rheumatoid factor positive palindromic type of rheumatoid. Yes. But if they have mild activity, then I would escalate and go to methotrexate. So I think it depends what you find on the. Obviously, in these patients, the CRP tends to be normal, and if you do the DAS 28, it may not be raised more than 2.1 to 3. But what we do in these cases, we do what we call an ultrasound DAS 28. So instead of feeling the joints, we do the ultrasound and then calculate and if we get a high result, then we will give methotrexate. Is that useful or not? I don't think it's been published, but EULAR is looking at incorporating Doppler in the disease assessment.
So this actually brings us end of today's session. So we are already 10 minutes over time. I would really take the opportunity to thank my worthy speakers, especially Ali Jawad and Hasni, who has been virtually present live for more than 2 hours with us. Hasni, you have been up early in the morning. I really heartfelt gratitude for you, especially. And I really would like to thank my audience. So what a lovely audience you are. So still we have 55 around participants, and there were like more than 70 throughout the session. My sincere thanks to my team, Azim, which has really helped me a lot during the last couple of days. Dr. Afakat, Dr. Mariam, you have been wonderful, like keep holding the fort while I was doing all this. And thank you. And we hope to see all of you in the upcoming PSR, which is going to be on 30th of September, 30th to 2nd of October. Hopefully things will be better, COVID situation by that time, and we would be able to meet everyone over here physically. So in the end, I would just like to say Pakistan Zindabad, and hope to see all of you and hear feedback from my senior colleagues, my mentors about these 3 topics in rheumatology. Thank you all.
Thank you.
Thank you. Thank you,
Thank
everyone.
you so much.
I just want to say thank you to Kalum, especially for attending the session. Kalum, thank you for attending. And
Thank you.
Rizwana, wonderful to see
Yes.
you. And of
Thank
course,
you so much.
all the rest. Wonderful.
So I just want to say thank you again and I just want to mention thank you to Shahir because he's been giving support in the background, and just want to acknowledge his help, especially in creating the polls for my talk. So thank you, Shahir, and thank you everyone, and we'll see you around.
Thank you for drawing my attention. How can I forget our corporate actually sponsors, Getz Pharma and the Scottmen, who have really helped us a lot in putting this show together. So thank you, Getz. Thank you, Scottmen.
Thank you, Getz, Scottman, and all of you. Wonderful activity.
It was great.
It was. It was.
Take care.
Take care.
Bye-bye.
Allah Hafiz to everyone.
Allah Hafiz.